Hi, welcome back to the Daughters of the Moon podcast. We're really grateful that you can join us for another week.
We sure are.
And today we are very lucky to have Dr. Kate Hadfield joining us. She is the pelvic floor naturopath doctor. She loves a challenge to status the quo in women's health. A rebel at heart, she enjoys examining a health issue, questioning its traditional assumptions, and creating holistic treatment plan in collaboration with her clients. She's a graduate of the Canadian College of Naturopathic Medicine and the University of Calgary. Dr. Kate deepened her women's health knowledge with holistic pelvic care training in Portland, Oregon. Passionate about nurturing the connection between physical illness and emotional well-being, she focuses on providing empowered, informed choice-based naturopathic pelvic care. Dr. Kate's areas of special interest are pelvic floor dysfunction, cervical dysplasia, infertility, PCOS, perinatal mood disorders, pregnancy, and postpartum health and pediatrics. Holistic pelvic care training level 1 and 2, pelvic floor therapy certification, pelvic health solutions certified birth doula, DONA certified lactation educator from the Baxter University. So welcome, Dr. Kate. We're really glad that you can join us here today.
We sure are.
Well, thank you so much for having me. You did a good job of reading my CV off. Everyone, so.
Thanks. I was hoping there was a couple of words there. I was like, oh, don't.
Yeah.
I'm wrong.
It's all good. No worries.
So yeah, welcome. And I was really lucky that I got to actually attend one of your seminars at the Banff Wellness Retreat. And next year, my mother is now coming along because
Yes, I am.
there was lots of fabulous people like you. So yeah, do you want to tell us a little bit about yourself?
Yeah, so I'll be speaking at the Banff Wellness Retreat again in October, and this time about two different things. So I'm really excited about that this year. So, like you said, I'm a naturopathic doctor practicing in Calgary and Canmore, Alberta, and I really like to say that I take a special interest in pelvic health or pelvic bowl health. And so what that means is kind of thinking beyond the pelvic floor. So most women at this point are familiar with the health of the pelvic floor. And when we think about that, we're really talking about pelvic floor muscles, pain, tension, things like that. But I think we can think about it in too much of an isolationist approach, because the pelvic bowl encompasses the pelvic floor muscles, but also the health of the uterus, the vagina, the ovaries, the bladder, the rectum. All of these things are pretty close with each other. And so the health of one affects the health of the others. So that's why I really like to expand upon the term and talk about pelvic bowl health as opposed to all of these things in isolation, because they're all interconnected.
They sure are. They really are.
Mm-hmm.
Yes. They really are. Yeah. I liked when you talked about that, because there was a lot of things that you talked about, from the fact of periods really shouldn't hurt to the fact of, when we go for our pap smears, that there is different size of the speculums. And I did not know that. So that I don't think a lot of people do know that.
That's true.
And that actually shouldn't be such an invasive procedure as it tends
to be. Yeah. So I just did a bunch of paps today. and that's what I say at each point in time. And you're certainly not alone in not knowing that. I once had a nurse come in for a pap exam, and she worked in an urgent care center, and she did not know that speculums came in different sizes because that urgent care center only stocked one size.
Wow.
And so that's incredible to me. And so I always say that paps are sensitive, but they shouldn't feel invasive, right? So we're not looking in an ear. Obviously, this is a sensitive part of the body. Let's call it what it is, but it should never feel invasive. And if it does, then something needs to change. And whether that's the, bedside manner of the practitioner who is providing the test, or it's something of a discomfort with the speculum itself, lubrication, whatever it is, they shouldn't be uncomfortable to that extent. So speculums are a good example. So they come in small, medium, and large. I have yet to open my large box. I don't think I will have to use that in the foreseeable future. I tend to use mediums, but I've been surprised at how often I've used smalls in practice. So if someone's had a really uncomfortable history with PAP exams, or they know they have a lot of pain or tension with their pelvic floor, maybe it's painful to put in a tampon, or sex is really uncomfortable, then I would always default to a small. There's no risk associated with using a smaller speculum, other than it might take longer for the provider to get the sample, but that's not a problem the patient should have to bear. Right.
Yeah, no, that, and
Yeah.
that's fair. And, I did, it was interesting because, yeah, that wasn't something. And then when you talked about periods not hurting, I was like, what?
Mhm.
I mean,
Yeah.
I was lucky I didn't have a lot of pain with mine, but, there is that. And you see
Yeah.
girls go through that all the
I know.
time. And I didn't
Yeah.
know.
Yeah, I mean, we're really socialized to accept that, periods are horrible and painful, and you just have to deal with it, right? And I think it is quite a shocking statement to say that no, periods shouldn't hurt, right? They should not be painful. There's nothing wrong with having an awareness that the period is going on. So like mild cramping, feeling a little more tired, something like that. Like that's fine. Like there's nothing amiss with that. But intense pain, significant cramping, putting you out for a week or two each month, that's unacceptable. And that doesn't need to happen. And it's really a sign that something else is going on. Really big sign. Yeah.
And so then that's where you'd be getting into something is happening in that pelvic bowl then that you need to look into in order to
Mhm.
help that.
Yeah. Yeah. So whenever someone presents with painful periods, it always is a deeper discussion as to what's going on with hormonal health, right? So we want to look at how regular are your cycles? Are they every 28 days? Are they longer? Are they irregular? That's one thing, because we really want to make sure that ovulation is happening on a consistent basis. So that's one thing we always look for. How long are you bleeding for? Is it really intense? Is it really heavy? Is it lighter? What's that week like leading up to your period? Is it significantly full of PMS symptoms? So irritability, breast tenderness, gas, bloating, diarrhea, sleep problems, or is that week okay? So we look at all of those different things, and all of that information helps me understand what's going on from a hormonal perspective. I'm lucky in Alberta, I can order labs as well. So I can order blood work here. And so sometimes we go to that to look at progesterone, estrogen, things like that. But even some other types of hormones can be really helpful. So looking at what the thyroid is doing, looking at what fasting blood sugar and insulin are doing are hugely important, because that's a really big mediator of what all of the sex hormones are doing. And so that should be another basic one that everyone is looking at. And then when anyone comes in with like significantly painful periods, I almost always assume endometriosis until proven otherwise, because endo is so difficult to diagnose here in Canada. Research shows that it takes between 7 to 10 years to get an endo diagnosis, which is unbelievably long when you're in debilitating pain on a monthly basis. And so I just kind of assume that endo is part of the picture, and we treat accordingly, because we're just not going to wait around for that type of a diagnosis. And it's hugely underdiagnosed here.
No kidding, especially 7 years. That's wild.
Yeah, it's just unacceptable.
Crazy, no. So
Yeah.
is this kind of sort of work in the menopausal time with a woman too? So that you can
Yeah.
talk about that too, where you're going through that change of life, and it can also be very discomforting. And
Yeah.
it really can take you away from your normalcy in life, during that time. So you can also work with that then.
Absolutely. And I think the first thing is like, let's make the distinction between menopause and perimenopause, right?
Right.
So menopause is defined as 12 months in a row of no period. right? So menopause is really an end point in the hormonal journey. And I've had some patients who get to 11 months of no period, then they get a period. Yeah. And it's like, go back to go, like, sorry, I'm not there. So that's always a tricky one. But perimenopause is that period of time before you hit menopause, where hormones are really going on a roller coaster ride. And it could be anywhere from 2 to 12 years. So sometimes it starts in your late 30s, but it could be, more progressively into your 40s as well. And so we like to think of the idea of heading towards menopause as like hormones doing this nice linear decline until you hit menopause, and then there's not a lot left. And unfortunately, that's just not true. So estrogen really goes on a roller coaster ride during perimenopause. Progesterone somewhat does a nice slow decline, but you really need to focus on a stable progesterone base. But estrogen can just go all over the place during that time. So it can be a really challenging period of time. And that's when other things like blood sugar and insulin really, really have a big role to play during that time period, and kind of buffer the effects of a fluctuating estrogen too.
Right.
Mhm.
Interesting. Yeah. It's interesting you say that, because I was told when I was 35, I was already starting my menopause. And I've asked some other doctors I've gone to, I said, no, I was told I was started this when I was like 35 years old. And they said, that's not possible. And I'm going, okay, well, that's their own thing, right? But it's so true with doctors and that. But it just was, it's nice to hear you say it, because it just sort of confirms that, because I knew it was something was happening. Changes and everything else. My B12 was down, and all kinds of things happening during it. And it's really interesting that you say it. So thank you.
Oh, of course. Yeah. And so, most likely menopause isn't going to happen in your 30s, right? So there could be premature ovarian failure going on, like if things just completely shut down. It's pretty unusual, but that can happen. And so what is more likely, again, is that perimenopause. So fluctuating hormone levels. They could start in your 30s, but it also could be other factors, like you start really losing skeletal muscle mass very quickly as you approach your late 30s. And the less skeletal muscle mass you have has a major impact on insulin, which then has a major impact on things like testosterone, progesterone, estrogen, the whole whack there. So it's really, really important to see what's going on metabolically, which again is blood sugar insulin balance, because it just it mediates every other sex hormone interaction. And that really starts to change after 35.
Wow.
Interesting.
Very interesting. I know my niece is a nurse, and when I was working, I told her one time that I couldn't get a break without 5 hours in first, and she just came undone and said, I'll write your doctor a note that you have to have a PB in 4 hours, the maximum. Okay. And then she explained the necessity and the urgency of that. And she said, you don't want to have incontinence later, do you, Aunt Barb?
Right.
I went, no, not if I can help.
Yeah.
So
and that's another thing. Like that's kind of like saying the period shouldn't hurt. Incontinence isn't normal, right? Like a little bit of urinary leakage is not normal. It's common, but common is not normal. Right. And so this is another thing that women have been told that they just have to live with. So, I've had patients who were told after they had a baby, like, well, what did you expect? You had a baby, with respect to leaking, right? And so that's just not true. So obviously the pelvic floor changes after a vaginal delivery or pregnancy in general, but there should not be incontinence going on. And if there is, again, there's a problem and we need to address it in some way.
Wow.
Yeah, it's a shame really that in today's society that we're still have all these myths that we're being told that aren't true, and that I'm so grateful that we have people like you that are going to these wellness retreats and teaching people and then spreading that word, because it's so nice to get the proper things that we're supposed to be doing for our bodies to empower ourselves as women, right? Especially.
Yeah, and that starts with education and awareness, right? Because if you've never been told that, periods shouldn't hurt, you shouldn't be leaking, all these types of things, then you'll just kind of assume that that's the status quo, because that's really what we get steeped in. from a cultural perspective, right? So it starts with that. And then I think it also goes into women demanding better from their care providers, right? And that takes a long time, but we do need to demand better for sure.
Yeah, we have to be our own champions when it comes to our health, that's for sure.
Yeah, you have to be a really strong advocate. Yeah, and especially now in the current system, with our healthcare being what it is, it's not designed to be proactive. So it's designed to be reactive, and I would much rather intervene before a problem starts than wait until there's overt disease, because that's much harder to come back from.
So what do you think is a good age? Like, I know we should always kind of be looking at our pelvic health, but as females, what age do you think that we really need to start paying attention to it?
Like specifically with the pelvic floor, you mean? Yeah. So I think if you have a pelvic floor, you should pay attention to it.
Oh,
Yeah. So in an ideal world, you should go see a pelvic floor physio or someone like me who's trained to do internal work before getting pregnant, right? Because you want to try to do everything you can to make sure there's no tension, there's no dysfunction, there's nothing going on before pregnancy. So that would be great. Even if we started to time it with, like, you know, your first PAP, that would be a great rollout of awareness of taking care of the pelvic floor, right? So I think it should start really early on and then continue either on an annual basis or every few years, depending on what's going on from a life perspective. But yeah, we should be doing it way earlier than we actually do.
Yeah.
So
and I agree with that, because I think that our youth, like, I know we're raising my granddaughter, and there's stuff that she doesn't know, and she's 17, right? And I feel like this is something that would be beneficial for her, because it would just help her to
put years ahead
for all the rest of her life, right? To, you know, be in good shape all ways, right? We want to encompass
it's a tougher sell to teenagers, that's for sure, right? But even if with teenagers, you know, you can start talking to them about, you know, what I call an empowered PAP, as opposed to just getting PAP exams, you know, trying to get that information out there from a young age and doing some education around hormones. That's huge. You know, I still see a lot of girls at 14, 15 getting put on oral contraceptive pills, right? So the birth control pill, because it's, you know, going to, quote, balance their hormones. So, you know, their periods turn on around 13. They're really difficult at the beginning, and so they get put on the pill to balance out their hormones, and that's not what the pill does. So I'm still seeing that happen a lot, and what we know now from the research is that the brain and ovaries need about 5 years of uninterrupted communication to establish a really healthy communication. And so if we interrupt that with external hormones, we don't really know what the long-term ramifications of that are going to be. And so it's not to knock hormonal contraceptive. Like, I'm glad we have this, of course, as an option, but I think we need to understand how to create healthy hormones first before intervening with something like that. And that starts with teenage girls, for sure.
Interesting. That's very interesting.
Yeah. So do you think that would lead to some of these things that we're doing incorrectly, or not knowing, just not having the information, to some of these things like the PCOS and some of these different things that seem to be more prevalent nowadays?
Does it ever?
It's really hard to say that for sure. I don't think any research has definitively been able to make that link. So it's hard to say that, but we sure do see a lot of PCOS. And so PCOS, for the listeners, is polycystic ovarian syndrome. And even that is, no, you don't know all the acronyms. But even that's not really well diagnosed from my perspective, because the name polycystic ovarian syndrome implies that you have to have cysts on the ovaries in order to get that diagnosis, and that's not true. You can have cysts on the ovaries, you may not. What's really going on there are changes to your periods, and the really common link between all of that is what's happening with insulin. So there's not just like one type of PCOS. We tend to think of it in that classic pre-diabetic overweight, abnormal hair growth, that type of picture. But that's just one type. I've seen a lot of lean PCOS in practice. So women who are athletic, active, lean, very healthy, and yet they're still struggling with irregular periods and fertility issues. So it's just good to note that there's lots of different types of PCOS. You know, with the long-term ramifications of interrupting that first 5 years, I don't think we really understand, because the importance of hormones has never been there from a medical perspective, right? So periods have always been looked at as a nuisance and kind of irrelevant to your overall health, where really our hormones and our periods specifically should be looked at as another vital sign. You know, obviously your blood pressure, heart rate, rest rate, that's all really important to letting us know what's going on. Our periods should be looked at that as well. And so shutting it down is not always the best decision. So we want to try to figure out what's going on first. And there's tons of research to support how, you know, important ovulation is for our health on a regular basis.
Right.
And so if you're messing with that, then you're going to interrupt ovulation, and that has a lot of health ramifications too. So, yeah.
Well, very interesting.
Yeah.
Would that go to the dryness of the pelvic and everything else? Like they talk about, you know, as you mature and things like that in life, they say, oh, well, that's just part of what happens, that you dry out or whatever. And I went, yeah, I think that's a bunch of crap too. Because you know, we're still women, right? And we still have whatever, but I've heard so much of that over the years, like, oh, that's just natural. Well,
That's just, yeah.
if you want to get it fixed, then you have to go on estrogen in order to tighten that up, sort of thing, to make it happen. And I don't agree with that either.
Yeah, it's so much of it is a cultural attitude as opposed to optimal health, right? So of course things change as we get older, like obviously that's true, but it doesn't have to be suffering, and it shouldn't impact your quality of life, right? Like no one needs to just settle for this like wearing out process, right? Like we need to we need to understand our health and try to cultivate it in a really intentional way the older we get as well. So in Alberta, I don't have prescription rights as a naturopathic doctor, so I don't have access to things like bioidentical hormones, you know, like estrogen, progesterone, things like that. In British Columbia and Ontario, they do. Like naturopaths do have access to that type of thing, and so in those jurisdictions, there's a lot of NDs who are quite comfortable prescribing estrogen, progesterone, DHEA, testosterone, things like that. And I think that that's a really viable option, depending on what the individual's case is like too. So, you know, there can be a lot of value in getting a prescription for like a topical estrogen. If there is a lot of vaginal dryness, I think that's quite reasonable. You just want to find a practitioner who really understands how to prescribe that in a meaningful way. And just, you know, again, that advocacy piece comes back. Like if someone's telling you, no, this is just the way it has to be, well, why? Where is that coming from? Is that true? Like, most of the time it's not.
That's true. That's true. So you're a real question person, obviously. You want to know.
Yeah. So I'm very much a rebel questioner. So if you ever do, there's a book called The Four Tendencies, and it looks at different personalities and kind of what motivates you in making decisions. So there's upholder, obliger, rebel, and questioner. And when I did it, I'm a rebel questioner. So I like to ask questions, obviously, and I just don't settle for things that I don't really see the need to. Like, why do things have to be that way?
It doesn't make sense to you. You question that too, and that's great.
Right.
That's wonderful.
Yeah, and understanding that like any medical provider, whether it's a physician or someone like myself, all we are is an opinion. That's it, right? So all we're doing is suggesting the best course of action to you from our education and our perspective, but then ultimately it's up to you to decide whether that makes sense for you or not. That's all we are. You know, and I think that's really important to remember, because there can be such a power differential with our healthcare practitioners. You know, I hate it when I hear people telling me like, oh, my doctor won't let me do something. And it's like, well, how are they not going to let you do whatever, right? Like it's your choice how you decide to proceed with your care.
Yeah.
I have a friend that actually had cervical cancer, and the doctor was going to take her in, and they wanted to, of course, operate and all that good stuff. And she refused. And
Yep.
she went to see a naturopath, and they walked her through the whole thing. And 1 year later, she was cancer free, and
Yeah.
she didn't take anything to do with the normal, what they call normal. She totally did the natural pathway, and she's still very healthy that way. So it was
Yeah.
it's nice for people to speak to people like you that do that, because it shows them that, yeah, you don't have to be, and you don't have to have that invasive procedure to make you better, right? And so
Yeah.
thank God
Yeah.
for
And oh, for sure. And so like cervical cancer, or what we refer to as cervical dysplasia, right? So that, spectrum of abnormal cells on the cervix before it becomes cancer. That's probably one of my favorite things to treat, because it's such a poorly done area of women's health. And women get told that they have to do certain things like LEAP procedures or hysterectomies to remove the problem. And I really push back on that one. I think we can do a significantly better job of supporting cervical dysplasia, and we're just not at this point. And ultimately, my goal with that too is, like, I'm not arguing for someone to avoid a hysterectomy or avoid a LEAP procedure. What I want them to do is to make that decision from a much more empowered place. Right. And if they can walk into that procedure feeling fully comfortable and informed, that's a win. Right. So it's not about, alternative versus mainstream medicine. I think it's about really helping our patients feel empowered, so they're not looking back and regretting whatever decision they've ultimately made.
Yeah.
True enough.
I
That's so
agree with
true.
you. Yeah, I think it's so important. I think we're starting to see that a lot more, about people becoming more empowered with their health, because we have doctors such as yourself that are telling people,
It's
like,
important.
you have to take this back into your own hands to some extent, to ask these questions and find the right fit
Yeah.
for you,
Yeah.
right? Because I think there's a perfect fit in balancing the Western and Eastern type
Absolutely.
of medicines. And I think we have to just follow what fits with us. And
Yeah.
if we go to somebody and it's like, this is not good, you need to move on and find the next one.
Yeah, that's a big sign. Your tummy says,
Yeah.
no,
Yeah. If
Yeah.
you have that choice available to you too, right? But
Yeah.
but that's certainly an issue up here in Canada, is that we don't always have choice of practitioner
Yes.
available to us, right?
Yes, that's true.
And so that can be really challenging
Yeah.
at the same time, right? And depending on how rural you are, you may have less choice available to you
Yeah,
as well.
we're
So
finding that here is there's not a lot of doctors around to go if you want to go to the doctors. So
yeah.
you find one, if they fit with you, you hold on for dear life. And
Yeah.
but it's nice. Like, I really enjoyed listening to you talk at the retreat, because I learned a lot of things that I could bring back and share with different people that
Hey.
that we, like, just different situations with the cysts on the ovaries and things like that, and the periods being painful, and sex should be painful, and these kind of things, right? That was really good to start that conversation, that people can then start looking for it. And
Yeah.
do you have any, like, online, I think I was looking on your website, you have some online information that people can look at?
I do. I have some things on my website. It's not quite where I would like it to be in an ideal world, but time is a bit of a premium these days. So I really like to use Instagram, because I find that it's just such a great visual medium. And I find that a lot of my target clientele are hanging out on Instagram these days. So I do my best to keep my feed up to date, or at least my stories. But I've been really amazed using Instagram whenever I post about, abnormal PAPs or cervical dysplasia. I've received messages from women all over the world trying to find more information and care alternatives for their abnormal PAPs. Like, I've had women reach out from Mississippi, from Singapore, from the UK, from Indonesia. Like I'm stunned. I'm like, how are you finding me? You know, some ND in Alberta, of all places, right? Like it's incredible. So, you know, there's absolutely a population searching for more information out there, right? And a lot of the quality of your healthcare is determined by geography and not by what's best for you. And that's a difficult thing to accept, because it shouldn't be like that, obviously, but it is a reality. So a great example of that is with pap tests. So Australia is in the process of doing away with pap tests, and they're only doing HPV testing. Right. So that's testing for the presence of HPV virus, which is the main virus that causes abnormal cells in the cervix.
Wow.
Right. And so the research is basically showing that you can't have abnormal cervical cells without the presence of HPV. So if you test for HPV and it's negative, your cervix is fine. If you test for HPV and it's positive, then maybe we do a pap to actually see what the cervix is doing. So Australia has moved away from pap and is just doing HPV testing.
Wow.
A huge advantage of that is that you can test it yourself. All HPV testing is a swab. And so anyone can insert a swab and, you know, move it around a bit and send it off to be tested. Like there's no skill involved in that whatsoever. And so in a rural country where we don't have practitioners available everywhere, where the nearest, you know, physician may be 2-3 hours away at best, you know, the availability of having an at-home HPV test for women is huge, absolutely huge. At this time, Health Canada has not approved any at-home HPV tests. In the States, you can buy them online.
Oh.
So, yep. So again, why is that?
Yeah.
Like there's no good reason for that whatsoever. There were some trials in BC where they were trialing out some HPV testing in rural locations. So hopefully one day, but it's just really important for women to understand that like the quality of care depends on where you live. Right. And we should be really pushing hard for increased access. You know, in some countries in Europe, a pelvic ultrasound is done on an annual basis as part of your routine care. And here you have to argue pretty hard to get a pelvic ultrasound done. So again, why is that?
Yeah, exactly.
Should not be.
No.
No.
And it's great. Like I love that you provide all that information on your Instagram, because I think we are searching for those answers, and it's great that you're so passionate about it and want to share it, right? Because you could just, you know, close off and just be like, nope, you got to come see me or else you don't get this information. So it's so wonderful that you, and I know, and from listening to you and talking to you today, like you're passionate about what you do. So
she felt that when she saw you anyways, when she said, Mom, she's old Mom, this girl is amazing.
Well, I think ideally we all get practitioners who are passionate about what they're doing, right? Like we should get excited about these types of things, right? Like you want to go to someone who's jazzed up about it and is willing to look into your case and think about it from a different perspective, right? Because just because this is what the literature says about something, you've got an individual in front of you and their case may be different. You know, maybe their labs come back as normal, but they're still experiencing symptoms. I mean, I've seen that happen before. What are we going to do? Just say, well, sorry, your labs are fine. See you later. No, they're still experiencing something. So let's figure that out, right?
Go deeper. Yeah. Find out why that is happening.
Yeah.
That's exactly.
Wow. And when I was 35, I was diagnosed. My doctor told me I needed to go in and get everything removed. But you know, hysterectomy and all the rest. And I went to a naturopath, and she put me, because I was cystic, and so she put me on these pills that I took, and she says, "Now, I want you to take those, then go back and have another test with your doctor and demand it, and see what happens." And so 6 months later, I went in and I had nothing.
Yep.
So thank you for
incredible,
such as yourself, because I mean, otherwise, I mean, I was just furious about it, because I said, I'm only 35 years old. I don't want a hysterectomy.
Yeah.
You know, I don't want that.
Yeah. Well, the uterus is really seen as an accessory gland, right? So like if you're done having babies, why do you need it anymore?
Exactly.
Just take it out, right? You know, the uterus is really only seen as for the purpose of pregnancy and fertility. That's it. That's really the only reason it exists. And so it's such a narrow way of looking at that area of the body, right? And it's so limiting. I mean, you're only defining it based off of whether or not you're going to have children. Like, maybe I want to hang on to my uterus even if I'm done having kids. Just a thought there. You know, it has some other utility in our bodies, but that's just how it's seen. You know, if it's causing you a lot of problems, just take it out. You know, that's still the main approach even now, I would say. So if the fibroids are an issue, if there's ongoing uterine bleeding that's unexplained, if there's cervical dysplasia that's a higher grade, usually the option is just get a hysterectomy, just cut it out. And that's it. And it's like, well, maybe there's other things that we could do, right?
And
So,
obviously there is, to help you that way. And women need to know this. And this
they need to know, they need to know there are options, because in some cases, absolutely, a hysterectomy is the right decision. And I'm very grateful that we have surgeons who can perform that in a good informed manner. That's great. But we absolutely jump to it too quickly.
Yeah,
absolutely.
I agree. We jump to a lot of things too quickly in the medicine field, sort of thing. It's just surgeons need a job too, I guess. I mean, I didn't mean that in a nice way. I mean that in a nice way.
Yeah, exactly. They're looking for things to do.
Yeah. And I think it's interesting because when you get some of this information, like there was so much about the pelvic bowl and the way that it tilts and the things that you were talking about at the retreat there, that was really interesting, because it was like, oh, I had no idea about that. I had no idea, like some things I knew, but like there was so much of what you don't even realize is encompassed in that, and looking at that area for health wise and our emotions to deal with that, right?
So I mean, that's another huge part of, I think, of the pelvic bowl, is the mental emotional aspect of it too. So we tend to think of the pelvic bowl as being for sex, paps, and babies, and that's kind of it, right? And then we don't go deeper to really look at, like, well, what emotions could be associated with vaginal conditions, with uterine conditions, with bladder conditions as well too. So if you step a little bit more outside of the mainstream and look at that mental emotional approach, you can start to see those connections. And I mean, I used to be a birth doula and attend births, and I don't think there was ever a birth I attended where there wasn't a moment during birth where, the energy of the room shifts in some type of intangible way, right? And there's so much written about that. And so I think to completely dissociate pelvic bowl health from the mental emotional or the energetics just does women a real disservice, because there's such a connection. So one of the things I do is called holistic pelvic care, and so that's internal vaginal work, so very similar to pelvic floor physio, but it brings that mental emotional approach to what's going on with pelvic floor health. And so there's been numerous times during those treatments where we're talking about things, or we find areas of tension or discomfort, and then these big emotional experiences come up at the same time. And I don't think the two are disconnected whatsoever. Or sometimes I'll find that a woman just kind of like lightly talks about, like, oh, this thing that happened as we're doing internal work. And then the pelvic bowl responds by getting really tense, by shifting in some way. And then I'll just say, I don't know if you noticed, but when you talked about, this traumatic experience, this past relationship, whatever, this is how the pelvic floor responded. And it just gives us another way kind of in to figure it all out too.
Wow.
Yeah. I love that, because it's such a mind body thing. And I think, like, for us, when we created this podcast, that was one of the things that we really wanted to touch on, was how much everything is so interwoven with each other. So that's wonderful. So thank you for sharing that with everybody. And
it's huge. So it was developed by a pelvic floor physio out of the States called Tammy Kent. She's still practicing in Portland, and that's who I did my training with. And she was working in a really high volume clinic, and she would notice that, if they released an area of tension in the pelvic floor, women would start spontaneously crying, and she had no framework to understand it. And so she created this incredible framework to try to help us understand, if there's tension in this area, what could that be? be connected to, what emotions show up, that type of thing. So, she's a wonderful resource, and she's written a couple of books that I would encourage everyone to look at, or access her audiobook as well too, because it's amazing. And there's another really strong connection between the pelvic bowl and the throat as well. So I've seen lots of times in practice where we find an area of tension and then the throat will go into spasm. And so there's such a strong connection there, or someone will start speaking, maybe a past event that they haven't acknowledged or haven't disclosed to anyone else. So there's such a strong connection between what's going on in our pelvic bowl, or that, energy center, and then, speaking our truth, wanting to be heard, feeling like you can't be heard, being told to be quiet, perhaps, or secret keeping. So there's such a strong connection between those two areas of the body.
Wow, that makes total sense.
Yeah.
It really does.
Yeah, it
right?
does.
Because we don't talk about that so much, or didn't used to. It's getting better. It's getting so much better.
It is, yeah. Yeah, it's getting better. And I mean, a great example, I think I probably talked about this at the wellness retreat too, is, even if we look at how parts of our anatomy are named, it's really quite enlightening, right? So there's lots of nerves, obviously, in the pelvic floor. One of the main nerves that innervates the pelvic floor and a lot of the pelvic organs is called the pudendal nerve. And so that Latin term, pudendum, where that comes from, that word means shame. So the actual nerve that innervates most of our pelvic floor is called shame.
Wow.
Incredible.
It is
incredible. So, wild. And like, that's what it's called in men too. So it's not like it's just women and then another good example is the term vagina itself, right? So that term means sheath, like a sword going into a sheath. And so you can't have a sheath without relation to another part of anatomy, right? And so even our anatomy is named in relation to male anatomy. Essentially, right? Yeah. So it's wild. Like it's just wild the more you start dissecting it and peeling back these layers to understand just how deep this sense of shame and dirtiness and keeping things quiet goes. Like it's a big one.
Isn't it? That's so the truth.
Yeah.
Because you find today when you speak openly with younger people, granddaughter in particular, we're talking about the moment, when you start talking openly about it, their thing is grandma, it's like, but this is real, and we have to talk about what's real with us women. We can't be afraid of that kind of thing. We can't be afraid of relating about that. And this is great. This conversation is wonderful.
Yeah, it is. Exactly. Talk to you for hours. I'm sure. So maybe you'll have to come back on again and give us more information, because this is like flown by. They're so full of so much information.
Phenomenal. What you're telling us, the information for women is beautiful. Thank you so much. It's beautiful.
Yeah. And we appreciate it, and we appreciate that you're empowering people to really take control and advocate for themselves to be healthy. And
that's the truth.
Yeah,
truth.
So can you tell us, our listeners, where to find you?
Yeah. So if you're in Alberta, you're welcome to come and see me, either in person or virtually. So one of the few good things to come out of the pandemic is that I can see anyone, no matter where they are, in Alberta. So I have some patients up in Edmonton who I've never met in real life, but I can, access care through Zoom and whatnot. So I'm in Canmore at the Canmore Health and Wellness Clinic, and I'm in Calgary at Vive Health as well. So they can find me online at Your Pelvic ND. So N is in naturopath.com. And then you can find me on Instagram. My handle is at Your Pelvic ND as well. So those are the best places to find me at this point.
Perfect. Well, wonderful. Well, thank you so much for joining us. We really, really appreciated all the information and your wonderful energy. Just love it.
Oh, and you have to come back and talk to us again.
Well, you can get me talking about pelvic health all the time. No worries, it's not an issue.
You're like this little book of information.
Yeah.
You know, it's yeah. She told me that. She said, "You're gonna love this girl, Mom." And you're just a sweetheart. Yeah,
Right
please
on.
come back and see us again. I'd love to talk more about the pelvic tilt and all that other stuff that we talked about a bit.
Yeah.
Yeah.
Yeah, this July, I'm actually taking a training up in Sundre, actually, about the Arvigo technique or Mayan abdominal massage, and that's all about optimal uterine positioning. And it's the first time both levels have been taught in Canada. So that's all like external, abdominal work. So as of August, I'll be able to offer that in practice as well too. And that's one of the things I'll likely be talking about in the fall at the Banff Wellness Retreat. So I'm really excited to add that to my practice.
Oh, that's awesome. That's
Beautiful.
amazing.
Beautiful.
Well, thank you so much. We really appreciate it. We really do hope you'll come back.
Yeah.
And our listeners, you know where to find her to get the information. And I've been following your Instagram, and there's lots of good information there. So that's great. And so again, we thank you. And to our listeners, please like, subscribe, leave us some positive reviews.
Yes, please.
That definitely helps in the podcast world. And we will see you all later, and have a magical week.
Yeah, you bet.